Good evening, everybody. Hello, I'm Zinat Rahman, Executive Director of the Institute of Politics, and we're so pleased to welcome you to a discussion with former Illinois Department of Health Director, Dr. Ngozi Ezike, and UChicago medicine physician, Dr. Thomas Fisher. Before one of our students formally introduces our guests in a few minutes, I'd like to mention a couple of upcoming events that we have at IOP and go over some housekeeping notes. So this Wednesday, May 18th, recently departed White House Press Secretary Jen Psaki will be in discussion with IOP Speaker Series Director Jennifer Steinhauer. This event will take place at Ida Noyes at 5:30. And on Friday, May 20th, IOP Founding Director David Axelrod will host a conversation about the midterms with former U.S. Senator Heidi Heitkamp, Cook Political Report publisher and editor-in-chief Amy Walter, and Republican strategist and publisher of The Bulwark and IOP Fellow this quarter, Sarah Longwell. The discussion will take place at Mendel Hall beginning at 3 p.m. That's on Friday. And on Monday, May 23rd, New York Times reporter Katie Zernicki will moderate a discussion about a potential post-Roe versus Wade America with demographer Diana Green Foster, University of Pittsburgh law professor Greer Donnelly, and pollster Tressa Undem. That conversation will take place here at the Quad Club at 5:30, and that's on Monday, May 23rd. And after tonight's moderated discussion, we'll open the floor to take questions from the audience. Please line up to ask your questions at the microphone, which will be just in the middle aisle. And as usual, we'll give priority to first questions to be asked by our students. As a housekeeping note, please make sure your phones are on silent. And we'll now hear formal introductions from Sabrina Wang, who's a third-year UChicago medical student and who's originally from Las Vegas. Please join me in welcoming Sabrina to the podium.
Hi, everyone, and welcome to Rebuilding Trust and Equity in Public Health, the latest event in the Institute of Politics Speaker Series. My name is Sabrina Wang. I am a third-year medical student here at the university and a health policy researcher at NORC at the University of Chicago. It's my pleasure to be welcoming you all today and to be introducing our wonderful speakers. First, we'll be joined by Dr. Ngozi Ezike, the former director of the Illinois Department of Public Health. Dr. Ezike is a board-certified internist and pediatrician, as well as a nationally recognized expert in healthcare within the juvenile justice system. In addition to her work leading the state of Illinois through the height of the COVID pandemic, Dr. Ezike has more than 15 years of experience working at the Cook County Health Center, where she served as medical director for the Austin Health Center and the Juvenile Temporary Detention Center. Given the breadth of Dr. Ezike's public service, I can think of no better person to speak about the state of public trust in our healthcare institutions, particularly in the COVID era. We'll also have the honor of hearing from Dr. Thomas Fisher, a board-certified emergency medicine physician here at the University of Chicago. Dr. Fisher is the author of the acclaimed memoir, The Emergency, A Year of Healing and Heartbreak in a Chicago ER, which explores and humanizes the challenges in our current healthcare system. In addition to his writing and clinical practice, Dr. Fisher previously served as a White House Fellow for the U.S. Department of Health and Human Services and has also held leadership roles within the private sector, within health insurance and Medicaid managed care companies. Dr. Fisher's experience, encompassing so many different parts of our healthcare system, will undoubtedly bring much richness to the conversation today. Please join me in welcoming Dr. Ngozi Ezike and Dr. Thomas Fisher.
So I couldn't be more excited and honored to be here on stage with you. While that was a glowing introduction, it doesn't even begin to describe the courage and grace that you showed over the course of the pandemic. In a historic time, you stood as a leader for all of us. Your moments on stage were held and transmitted across my family, across the nation, and you received a number of national leadership awards for them, and they were well-deserved. I wonder if we can go all the way back. Before you were the public health director, one day you were named. You will be the next. There was no COVID on the horizon. What is it that you thought you would be doing in this role? What were your expectations?
No, it was such an exciting opportunity. I was, when I even got the call to say you've been added to a short list of people who'd be considered to be the director of IDPH, I was just like, oh, somebody's punking me. Like, this is a joke, because I didn't feel like who knew the work I was doing? I was kind of doing it, in secrecy, but thinking about the opportunity to do, affect programs that would actually help all people, not just some people, that you could actually work on important things like promoting measles vaccinations, because vaccines are really important, and trying to stem off the measles outbreaks that we were seeing across the country, thinking about the opioid overdoses, thinking about women's health, environmental health, lead poisoning, thinking about how that would affect children in their future years. Like, there was just so many things. There were literally 200 and something different programs at IDPH that were working to keep people safe and really extend, the vitality of health, not just, keeping you alive, but keeping you, vibrant and alive. And so I was so excited to tackle all of those. Even some of the programs that I wasn't even familiar were within the scope of IDPH. And we got started with that for about a year.
Yeah.
We got started with that for about a year. And really, had some amazing initiatives, getting to zero, trying to make sure that HIV/AIDS became a thing of the past, making sure everyone knew about the different ways that you can, prevent transmission. So obviously, this novel coronavirus came along, but that other work couldn't stop, right? And so I know a lot of people were like, oh my gosh, only COVID, but we can't stop, providing resources, housing for people with HIV. We continued to make sure that organizations got the money for breast and cervical cancer screening. We still had issues with childhood vaccinations. So all of, hospital-acquired infections, not COVID, but other things, like all of that work had to continue in addition to the new work that was added on.
You'd been a practicing pediatrician. You'd worked...
And internist.
And internist.
Yeah.
And you'd worked in various organizations across the Chicagoland area that had affiliations with our local or county and state government. What were the roles that prepared you best for what you ultimately got yourself into, both in the first year, but then subsequently as well?
No, I think when you work for a safety net, when you're working for an institution whose mission is to care for people regardless of their ability to pay, you are getting to the core of the people who need assistance, right? And so I have already worked, essentially exclusively with people who are, recent immigrants, underinsured, uninsured, don't speak English as their primary language, lower education, all of those, that was my patient base, that was my patient population. And then add to it being in corrections, working in the Cook County Jail, working in the detention center, seeing that population, who a lot are from that first subset that I described, but also having that unique challenge of being in that correctional setting, if it's actually correctional, in a correctional setting, and being able to make sure that you are still giving people the appropriate care that they need, again, regardless of their status as being, in prison or in jail or in a detention center. So.
I've heard you speak so far about the most vulnerable in our population, people who can't pay, people who are in the correctional facilities, those who are children. Has equity always been a theme of your professional work?
It has. I always wanted to serve people who traditionally have not been served. And so that is why my first job out of residency, could go to any healthcare system, but intentionally wanted to be at Cook County. And so I am, that's my passion. That's always what I wanted to do. It is so rewarding. It is so rewarding. And it actually turned out to be just the training that I needed to be able to take on, not that I chose it, but take on a pandemic and make sure I had that broader lens that remembers that there are many different parts of the population, and being able to be intentional about knowing that one solution does not fit all, just like we know one size doesn't fit all, that one solution doesn't fit all, and that you need such, parsed out different kinds of solutions, different kinds of thinking to really serve everyone.
That's important, and I want to come back to that when we talk about COVID, which, maybe we should start talking about that now. So I practice emergency medicine, and pandemics are something we train for. But the other place in the American healthcare system where they're always prepared is the public health system. Do you remember when you first caught wind of COVID and thought, ooh, this could be a problem?
So I was, so New Year's coming into 2020, I was overseas, and even as we were counting down to the new year, there were also reports on BBC, CNN, talking about, something going on in China, Wuhan specifically. It's like, whoa, where's Wuhan? And wasn't thinking that much of it, actually was not thinking much of it. And so by the time I came back stateside, in January already, right after the holidays, the CDC was convening all of the state health directors, especially some of the major states that are, major sites for international travel to land from China. And so we were having meetings, getting intel that, okay, we might have to set up some quarantining, like the plans were like evolving in real time. But us having Chicago and having so many flights that were coming in, we were like front and center stage thinking about, okay, if people come and they're symptomatic or they're this, like where could we quarantine everybody first and check for symptoms before we let them move on? What if they're in like all of those plans, like everyone was just kind of spitfiring ideas on how to do that. Eventually there was a travel ban, and so there were fewer flights coming in, but there were still, different groups coming in. But, we had our first case January 24th. And I was like, yeah, this person had come straight from Wuhan, no biggie. Like, okay, yeah, like I get it. And then the second case was the spouse of the Wuhan traveler. So it's like, okay, yeah, super close contact, lived in the same house, yes. And then I think the third case was someone had come from Italy, and I think we had known that Italy was a hot spot at that time. It was a student who was studying abroad, came over, okay. And then it started getting into a couple from California with no travel, no Italy, no Wuhan, no contact with any of those people. And it was like, oh, okay. And so, that's okay, but that's 5 cases that we knew of. Then it was like trickling cases by March 17th. So it went from January 24th, March 17th, I think we announced 55 new cases. And I think our first death. And then it was like, oh, okay.
Yeah.
Like we knew this tsunami was really unfolding. And I think it was right around that time, was it the 14th? That the governor issued, told kids that they were gonna stay at home. And which is, I think, the first time that has ever happened, in this state. And of course, all 50 states ended up doing, something similar.
Yeah. I was practicing during that time frame, and one of the things that I recall really clearly was we didn't really have tests.
Right.
And so I would look at the statistics that were being distributed from various outlets, and I was like, there's a lot of people coughing and sneezing. I wonder if we really only have X number of cases.
Yeah.
What kind of guidance were you getting from the CDC as this evolved? Because we were looking for it also on the clinical side.
Yeah. So, I mean, if I'm remembering like the initial flyers, and the flyers were saying, to be a case or to, to have high suspicion that, initially you came from Wuhan, like it said, like, did you come from Wuhan? I think then it extended to, oh, okay, you came from China, and then you had, cough, respiratory difficulties, shortness of breath, fever. Like, it never even talked about what we came to learn as, our information grew, that it was the great mimicker. You could have loss of taste or smell, you could have just diarrhea. So there were just, the case definition didn't even understand the whole breadth at that time. And of course, the testing, not having testing supplies. In the beginning, every single test had to be sent to the CDC, and they were every state was sending all of their tests to the CDC, and there was this backlog of weeks, to get results. Actually, Illinois was the first. Our public health department was the first to be able to do the tests on site. And so then once we got that ability, we tried to ramp up. So we actually had way more testing than anyone else, but it was still like hardly anything. At some point, we were literally like, yeah, if you're coughing or you were around somebody who was diagnosed, you have it too. You don't need a test. Just you have. I mean, so we literally had to change the message from if it walks like a duck, quacks like a duck, it's a duck, to no, everybody go get tested, just because the resource was not there.
I mean, you kind of talk through it really quickly as though, oh yeah, and then we did this and then we did that, but that is an incredible leadership task to stand up a testing facility that is reliable in real time for a disease that we've never seen before.
That's right. No, an amazing.
How did you do that?
No, an amazing team. We have, I don't think people know just the breadth of people that make up the state health department, but we have virologists and microbiologists and just a whole team of labs. We literally have 3 state labs, one in Chicago, one in Springfield, and then one south in Carbondale. And so at our Carbondale, we had this amazing virologist that had actually created an assay that could test for the virus, and we got the approval from the CDC. Again, first public health department in the country to get that done. But it really helped us to know quicker, identify people quickly, and know who we were telling to isolate and quarantine, actually get real results. And then we went on to share that technology with other labs, whether academic institutions, hospitals, so that they could ramp up their ability to test. So we became a very high volume testing state, which I think is really helpful too.
I think it really changed both the way we perceived on the front lines that we were being taken care of. It also changed the way the conversation in communities were around the disease, because it was harder to live in denial and say, oh, it's just a cold, when in fact, no, we can get testing. As that first wave peaked and then started to fall, we saw 2 weeks later the deaths starting to peak and fall. And then very soon after that, there was a WBEZ report about who was dying, in fact. And we learned quite quickly that it was people who were out working, and they tended to be in that first wave. They were mostly Black folks. We started out with a little conversation about there need to be different solutions for different people, and equity is a core component of the work that you've been doing. How did you digest that information when it came out, and what kind of changes or plans did that lead to?
I think one of the most important pieces of the entire pandemic, if you say the top 3 things were communication, and 3, communication. And it was really, because first, from day one, the myths, abound. So it was first, it was no, Black people don't get this. This is not a Black people thing. It was in China, it was in Europe. We're immune. We're finally something that we don't get. That's what I heard people say. And it was yeah, not so fast. Not so fast. So really trying to, make sure everybody knew that this was everyone's problem, really trying to get the information about who was at highest risk of having a very untoward course in terms of the risk factors, whether, of course, we knew advanced age, immunocompromised people, but understanding that people who have diabetes, who have hypertension, who are obese, which we know the groups that have higher percentages and proportions of that. So really trying to get that information out. Again, in a time of almost just intense anxiety, hysteria for some. It was hard to get the message because there were so many things in people's heads, so many things in people's ears, that it was hard to get the message out. So one of the most important things that we did with IDPH is to start a community ambassador program. So we just wanted ordinary people, moms, coaches, teachers, anybody who was willing to put information from IDPH on their social media, just to because people are like, oh, I don't trust the government. I don't want to hear what, government has to say. I don't trust them. But sometimes if it's coming from a different source, you're just more amenable to see, like, what is my friend posting? Oh, she believes that COVID is real too? Like, maybe that will spark a discussion. Maybe that will cause people to engage, maybe look into it a little further. If somebody that you actually know, trust, maybe even respect, is saying some of this information, that might be the person that might get you to look further and say, is this real? Should I get tested if I start having symptoms? So we had trying to get ambassadors in every single county. And, there are 102 counties in Illinois. So by the end, we had, almost 2,000 ambassadors, people who were all pushing out these messages, who represented, different ages, people, different, languages. And then we kept pushing things out, and trying to tailor it to the different groups so that there was another way besides people, not everybody's clicking onto cdc.gov. And although we had more followers on social media than we've ever had, everybody is not following IDPH to get their news. And in fact, many people would say like, oh, I get my stuff from, TikTok or Instagram, So really having, building out our communications team. We had one communications person when I started at IDPH. Now we have consultants and a whole team that, we're up to like a dozen people. We have somebody who helps put stuff together for Instagram and TikTok. And then we have people who are making sure we're putting stuff out in different languages. So we understand how important communication is to a pandemic, to any effort in terms of making sure people actually know what's happening.
Let's spend a little time on that, because you're a gifted communicator, and the cadence, your regular cadence of public addressing, was something we could all set a metronome to and understand what was coming and what was coming next. The flip side of that is online, half of what was out there was incorrect. Intentionally so, in fact. And by the time we got to vaccination, it was learned that there were 15 who put out 60% of the entire anti-vax information online. None of that, even though that was known, the Facebook, the Twitters, the Instagrams, the TikTok, they were not taking them down. How did you address that? How did you engage that, or was it just something you let go?
No, I think that, I don't know that we dealt with that well. I know we sat in meetings with the Emergency Management Agency, and Director Tate Nadeau was giving us all the intel about how they literally had mapped it out. There were Russian bots that were putting out, this bogus information. But it is so much harder to chase a myth, right? Once it's out there and you're chasing to say, no, that's not true, like it's already gone around everywhere. So, we had hundreds and hundreds of town halls in different languages for different groups, trying to enlist so many partners to try to share the information. But I think it was an uphill battle. I mean, I remember having a town hall for my IDPH staff, because I was like, you have to make sure that your own team has all the right information. And people in my own team were asking about the microchip. And I was like, ooh. Oh, okay. So it was just that was a significant challenge that I don't think we completely overcame. We were just always trying to climb up that hill.
Yeah. I worry about that still.
Yes.
I'm not confident that we've fully mastered that challenge as it continues to influence so much of our public health information with pollution ultimately. But one of the things you did do is, it was those conversations that you presented to the population. I remember one, as you were recounting the death toll, you broke into tears, and I assume that was a reflection of the recognition that these are citizens, these are people, these are Chicagoans and people in Illinois who were lost. In the midst of all that chaos and with the pace that you're running, how did you hold on to your humanity?
I'm very fortunate to be grounded with an amazing spouse, had 4 amazing children, one who's here today, the first year here at USC. And so we weren't as isolated as maybe, sorry for the call out. She's probably like, really, Mom?
We won't have her stand up.
Really, Mom? Okay. Just really wanted, at least had our little insular, group. Had our, we weren't completely alone. The kids were not completely isolated, even if they weren't, at school. Had my faith, was doing church online, reading the word, the things that ground me. So, trying to do all that thing, but I would say like having family, having faith, like that's what kept me. And was a little bit of the insulation, although, it's just a mass casualty, mass, traumatic event for everyone. Like nobody was, I don't think anybody can say that they are not touched or unscathed. Like it's just something that we're all still feeling the effects of and will for, unfortunately, lifetimes, generations, both in terms of the individuals who lost loved ones, parents, grandparents, spouses, and, even if they didn't lose people, maybe lost livelihoods, or just lived under this shroud of complete anxiety and fear, for 2+ years.
Yeah.
I mean, there's nothing like this that I think most people can relate to.
Yeah. I mean, I didn't think I'd ever be in a room like this again in 2020. I just didn't know when that would happen. I mean, when I worked in government, I recall doing some war games around a respiratory virus that killed 10% of the population. And I will spare you all the details, but it didn't go well, right? And so the idea that we can actually have a conversation, even if masked, is a testimony to a lot of hard work and leadership, but also technology. I mean, an mRNA vaccine that came out that quick is unheard of. We would not be here were it not for that.
That's right.
There was a little luck involved too, but also a lot of preparation. Tell me about the rollout of the vaccine. You guys, your team, your leadership was right out in front of that, prioritizing who ought to go first and what were the messaging around that allows for us to be here now.
Yeah. So, I mean, first, no one knew exactly when the vaccine was coming. So we would have meetings with the feds. Dozens of meetings, every single week, with updates, trying to tell us, where we are with it. Trials have started, and then, unfortunately, like the one lesson that we know for sure is that like politics and pandemics don't mix, right? And so when you would hear a message like, oh, we're going to have it out immediately, we're going to have it out before the election, and then someone else would be like, no, we're hope maybe first quarter, 2021, maybe second quarter. So we're just like, okay, we're making our plans, but don't know when this would roll out. So it was actually like, oh my goodness, December, like it is really happening. We had all these talks about, national talks in terms of where do you start? Who do you give it to? Because we knew at the beginning there were just not going to be enough for everyone, right? That they knew that, like you're just making those first batches. There's only a little bit. Who do you start with? And so we all were involved in these discussions trying to figure it out. But as we talked to all the other state health officers, like we wanted to be, work off of a national framework so that you don't have one state. Well, why are they giving it to doctors first here and then they're giving it to, seniors first here? And like, why, what do you know that they don't, which happened with every other thing and we had to deal with. But, so we took what the CDC kind of guidance, what the National Academies of Medicine, all of their recommendations and just, tweak things. Like the initial recommendation was long-term care settings, and then our healthcare workers, and then you still have to parse it out. Like who counts? Like is it the healthcare worker? The ER doc is a clear yes. But what about the person who's doing telehealth and has never stepped out of their home? But they're like, but I'm a healthcare worker. So trying to like parse all that out. Everyone was like, no, me. Which unfortunately switched very quickly, where it was like, no, me, not it. How did that happen? But trying to, then it was like the second tier, like then there's 1A, 1B, 1C. Okay, next would be the 65 plus. And, I looked at our data in terms of the people who were perishing and thought about the life expectancy and said, well, if you wait, I was 75. It was 75 and over. And I was like, if you look at the life expectancy of Black and brown people, like, we ain't even getting it. We're not getting there.
That's
so
right.
If you're waiting till 75, you have so many people that won't even have a chance because they don't get to age 75. So it's like, Governor, based on this data that I have, I think we can't do 75 in the terms of the equity lens. You would want to lower that to 65. And he was, again, amazing leadership and was really trying to follow guidance. And so we had made it 65, which nationally it did change to that shortly thereafter. So just a lot of tough decisions to make. Again, there's no book, nobody studied this in med school, nobody really had the right answers. Even we did a similar preparation. We did a tabletop exercise with multiple states and the feds where we had a similar thing, and it was August of 19, a simulated respiratory virus from China, that would spread around the world. But in the tabletop, we had vaccines like right away, and it was just mobilizing the vaccines quickly enough for this flu virus. So having something kind of similar happen, but having to wait, 10 months to have a vaccine, and meanwhile, just the significant amount of lives lost. Although the sad fact is that more people have died since we've had vaccines than before. So clearly a lot of issues that play into that.
One of those goes back to misinformation.
Right.
And part of that misinformation is a national concerted effort that is connected to a lot of other tentacles. And I wonder if we can pivot a little bit to some of those things. The CDC just released data that showed there was a 35% increase in gun deaths between 2019 and 2020. 35% increase. Just this weekend, Catherine Massey was 72. She was a gun control advocate in Buffalo. She was shot and killed by a white supremacist. Are guns a public health issue?
When we think about public health, we think of, the health of the public. So obviously, guns play a role in the health of the public in a clearly negative way. Of course, we know that guns are for sport and for hunting. Yes, we understand that. But this dramatic rise that you've quoted, which our numbers would shake out similarly, if not worse, here in Illinois. We know that gun violence is a public health. That was one of the things that we were already talking about. We had multiple legislators that were we were convening all kinds of summits and meetings saying, what's the best way to tackle this? And so, it was unfortunately significantly exacerbated by the pandemic.
I saw it in the emergency department. That summer, we saw just one of the most bloody summers I've ever seen. We're the busiest trauma center in the state, and you saw young people with no school, and the elders had either died or were taking cover. All of the gyms were closed, the churches were closed, the after school. They had nothing to do, and there was a proliferation of guns on the street. Given that this has been a conversation piece, I'm not the first one to raise it. I'm coming from a tradition, and so are you. How do we, when you were in your role, what was the tenor of the conversation around guns as public health? Certainly you didn't have the capacity to do it while you were also fighting a pandemic, but is there room for that conversation for the next public health director?
There are so many issues to tackle, but I think you have to see this as one that ranks high, and so we're constantly trying to walk and talk and chew gum at the same time, and try to deal with all of these issues at the same time, because all of them are so pressing that I mean, my typical week even before COVID was, okay, opioid update, okay, HIV update, okay, the Black Caucus wants to talk about gun violence, mental health, what are we going to do about, there's an increase in depression, there's a dearth of mental health specialists, what's happening with partnering with either Planned Parenthood, breast and service, I mean, like, there's a lot to cover, but it's not like, oh, skip that, don't fund that, that's not important. Like, everything is critical, and they actually all somehow, often dovetail together and all relate to each other. So there's nothing that can be erased or taken off, but you just need all hands on deck, and it can't be public health agency. Like, we need all of government, we need all of the nonprofits, we need all of the hospital systems, we need all of the religious organizations. Like, all of these problems require an all-in approach from all parties. We saw that in COVID, and it was super effective. Like, everybody was a partner. Everybody was, hosting events for vaccination, or letting us have a testing site, putting out information, sponsoring a town hall. Like, everyone had to be a part of this. And I think we need to use that lens to tackle these other problems and say, everybody sign up. Like, you have a role in these issues too. Let's figure out what your role is, and let's see how we're going to tackle this together.
That's optimistic. I feel good about that. I want to go back to Buffalo for a second, because this speaks to one of the challenges, which is the Lawns grocery store where the shooting happened, where the white supremacists drove 200 miles to find that grocery store, was previously a food desert. The community that had been segregated didn't have any food options because they'd been separated from it by a highway. And it took them 10 years of advocacy before they could get a grocery store. 10 years. When we think about these all-in approaches, are they complicated by these issues of race and poverty? Can we actually get all-in approaches for these vulnerable populations? We've seen Whole Foods come to Inglewood and then pull out. Are these things that public health departments can lead?
I mean, we have been. I mean, again, I remind you that this is a huge state, and, maybe Chicago has food deserts, but if you go further south, if you go downstate, go to southern Illinois, like, it's on a different level. East St. Louis, again, a local health department there, Black neighborhood. I mean, I was driving with the public health director for the that local area, and she's showing me, like, the one grocery store that's in the area. And they're like, and the produce, they said, I can't say bad, it's no good, but it's the one grocery store that they have, and they're threatening to close. And so we were trying to figure out, like, what pressure can we put on local legislators, state legislators, to not let it close. So this is something that's happening every day, and it is public health, and it is our role. You can't tackle diabetes and heart disease if you can't eat right, I mean, that's one issue. You also need safe spaces and places for recreation. You can't tackle obesity and diabetes if you can't feel safe to walk a mile or two in your neighborhood, right? And so all of these things, everything is public health. Everything is public health, but it's not stuff that we can do by ourselves. It just needs a lot of partners.
So is that a strength or a weakness of public health? The fact that look, I have a public health degree as well. I think very much from a public health mindset. Well, I was trained in this space, and you have a lifetime of experience, which is better than any degree. And we know these things conceptually, that our bodies are a function of where we live, learn, work, and play, more so than anything genetic or biologic. The segregation that created that neighborhood in Buffalo were policy decisions in the 50s and 60s to divide the community from its resources by a highway and create a food desert. The community fought against it. Similarly, in Inglewood, it was a highway. The Dan Ryan cut right through a black community in order to separate communities from its resources. And there were a number of tax dollars put in to help the Whole Foods come, and then the Whole Foods wasn't making enough money, and they kept the tax dollars but didn't keep the grocery store. From a public health standpoint, we call these social determinants, and we think very carefully about, well, how should we ameliorate these things with thoughtful research, directed policies, and measurements in the bodies of the communities that we work in. You're soon going to take the helm of a medical center in a community just like this. What are the lessons that you can bring? And now that you've seen how it can be an all or, where you need everybody involved, what are the lessons that you'll bring, and how do you think about this next opportunity?
Yeah. No, I'm really excited about this next opportunity because I'm joining a system that gets it already. I'm not coming and saying, hey, all this stuff matters. They have an urban health institute. They are already studying the determinants of health. They are working on training people to be community health workers so that they can go and educate the masses to try to keep people out of the hospital. So they get the connection that the community has to have with the healthcare system, with the social determinants, bringing jobs, bringing opportunity. So I'm excited to join an incredible system that already gets it, and then just see, what more can we do. But that is definitely a system in a very underserved community that understands all of that intersectionality and is working on it, and I hope to be able to add something to that.
How will you measure success?
Yeah.
How will you know that it's working? Because it's a safety net provider.
Yeah.
I did, when I was training, I worked on the trauma service there, and your Spanish will come in handy. It is a community that needs help, and also has a lot of collective resources and there's some stability around that. When you come in as the helm of this institution, an institution that may need change, what will you identify as your opportunity, and how will you know that you've been successful?
Yeah. So I really think, you can't be all Pollyanna. At the end of the day, you have to be able to keep the doors open, right? And that means funds, that means resources. When you talk about safety net hospitals, that basically just means that, most of the patients are on, government insurance. For Sinai, average safety nets, maybe 40% are Medicaid. Sinai's 85%. And we know that Medicaid by itself will not keep the doors open. The services that you give will not be fully reimbursed with the reimbursement that will come back from Medicaid. So really innovative solutions. I think one big thing that I think will be expected, that I understand, is, where can we get additional resources? Where are we going to get those additional resources? Where can we tap in for additional resources? Because just getting more people enrolled in Medicaid doesn't even get it done. It doesn't get it done. You're a deficit with each additional Medicaid patient. So finding resources is going to be one. Just morale. I think looking at what healthcare providers, everybody in the healthcare system, the nurses, the doctors, the environmental workers, the plant people, everyone has just been through a lot. And so trying to figure out how to bring up morale, how to retain staff.
Yeah.
We're pardon the pun, bleeding out hospital workers where they're just like, I'm out. Then what else can I do? And so trying to remind people why they answered the call and try to reinvigorate that and get people to stay. because the community does need them. So I think those are two of the places that I know you can look at and say, how are we doing with retention? How are we doing with resources? Those are important places to start, but there are so many other things to do as well.
The West Side is very fortunate to have that institution.
Yes.
And to have you at the helm of it. Is there an opportunity to marry what happens at an individual medical center with its responsibility to the communities? And if any place has done it well, it's been Mount Sinai, which gets a tax benefit from its community in order to support its clinical endeavors. What is the responsibility back to the community?
Yeah, I think it understands, the system understands that it is part of the community, and therefore, everyone has a role in community. I think we've gotten a little bit away where, this rugged individualism and just each person for themselves, which it can't sustain the progress of a society. And so Sinai understands that it is a member, if you will, of a community, and that it has a role to play. The doctors go into the community and do all kinds of free, health screenings, educational workshops, really are embedded. There's so many community groups, so many nonprofits that also work in the space that partner with Sinai. So there's a lot of that collaboration, understanding that we are all part of this community, and it's, together we stand, and divided, we fall and fail.
My last question before we go to the audience is, as you walk out of the Illinois Department of Public Health Director's chair, what was the most crucial learning about yourself or about COVID in that time frame that you didn't have before, but you have now?
I think one of the things is just all the amazing relationships.
Yeah.
It's really all about the team. Surrounding yourself with the right team, people unified in mission, not unified in how we think, because we like to have all different kinds of people who will come at problems from different directions to give this the most robust solution. But just having an amazing team, having those great relationships where it's work, it's personal, it's meshed because we were spending so much time together. My chief of staff, we were on calls till 12 o'clock at night, routinely. He literally has become part of the family. My husband was like, "Oh, say hi to the chief of staff." He would ask about, "Okay, how's hubby?" Because we are keeping each other away from our families. But just having that incredible team, understanding how much connection we need, how much people need to work together. I was talking to public health leaders in South Africa, in London, in Nigeria, and South Korea. We understand that if we are told to do something because it will benefit our community, then that's what we do. And I'm like, oh, well, what do I do when we ain't got that? What happens when we ain't got that?
Yeah.
They're like, you don't have that? So really trying to understand how you foster that community and make everyone feel a part. I don't think I saw that, but that's something that needs to be done.
Thank you. And so we have time for questions. I want to make sure we have the opportunity, particularly for the students who might want to ask questions. There's a microphone here in the middle.
One at a time, please. Too many people at once.
This is a question from online, from Safri Dunn. With the mask requirement being a modified quarantine, Evanston High School brought back a mask mandate for students and staff today. Can you comment on students' due process rights in accordance with Illinois Public Health Act, which gives the health department supreme authority in matters of quarantine?
So I think maybe I would take issue with the first part that says that masks are a form of quarantine. I'm not sure that that's accurate. And so things are based on that, then it's hard for me to kind of follow that logic. I would say masks are a form of protection against disease. It's not the only form, but when you think about the different options in terms of how you slow the spread of a disease, you can close things down and force people to physically, isolate and quarantine. But then you have other measures that are less, less drastic, i.e. wearing a mask, which allows us to still convene, still be in person here, still connect with others, do work together. So I just have a problem with the idea that masks are a form of quarantine.
Getting back to the title of the program, and you alluded to this a lot during your conversation, you were talking about misinformation and so forth. Do you have thoughts on how, we saw trust erode with public health institutions and all of our federal institutions across the country, across all types of demographics, red states, blue states. Do you have formulas in your mind for how that trust can be regained?
I think, as this author can tell you, I think storytelling is a very important part. I think having, whether it's books or movies that kind of explain the process, I think there's just a lot of gaps in terms of people don't understand how the scientific process works. And so not understanding that if you have a brand new virus that comes out, we are learning as we're going along. I think that's probably just uncomfortable for people to, because you think, let me just Google, and whatever I Google, I can get a textbook, I can get the information. But when you have something that is new, where you don't have years of research. When I graduated from medical school, I don't think West Nile virus had been identified. But now, I have to know about that. It's something that we've identified since. So understanding how that scientific process works, that, something happens, you test, you get one conclusion, you have to have a body of scientific work, a body of studies to help guide you. I think that's not well understood. So I think understanding that, I think we absolutely need to work on teaching people how do you evaluate the source of the information that you are imbibing, right? So, you can just type in a search and then an answer will come up, but how do you know that that is from a credible source that should be offering that answer, that is giving an accurate answer? And so again, us coming up, I didn't grow up with the internet, so there is no education that I have on this is how you make sure that the source, where did this actually come from, this information? But that is something that we need to get to, where we are teaching people to be discriminating in looking at their information and saying, okay, what's the source? Is this a credible source? So that we're not just so quick to imbibe information that's just wholly inaccurate.
Hi, my name is Ellen. I have a general admission ticket, but I do have a connection in that I was a hospital executive at the medical center here. My question is to both of you, picking up on the theme of misinformation, there were a number of top leaders like yourself, as well as national experts who we really relied on for information, sound information. And yet at the same time, there were a number of your physician colleagues on a national stage that clearly had intentions to misinform the public. So my question to both of you is, for your physician colleagues, how would you recommend that not only the public, do their research and try to go to efficacious sources, but what is the responsibility of your respective medical colleagues to combat your own colleagues from disseminating that misinformation? If that's clear.
You taking that one?
Yeah, I can start. You mentioned a handful of people in particular who were mass producers of misinformation, many of whom were physicians. Took platforms online and debated without good intention. and actively disseminated misinformation. I think that the physician community also was engaged in that debate and was pushing back in many ways. I think that there are tools around certification that a number of my professional societies stood up and made clear statements, even though they didn't necessarily target the individuals. I also think that there's a responsibility from social media platforms to be really clear about misinformation and, in fact, remove dangerous misinformation, a responsibility they haven't yet seized. I find it challenging when the Surgeon General stood up and made an announcement that they were these 15 sources on Facebook that were producing 60% of the misinformation around vaccines, and Facebook did nothing. If you think back to World War II, there was a war effort. Industries were asked to produce war material, and they consented. Not because they had to, but because they realized we were in this together, and profit was not as important as being in this together. We don't see that same level of responsibility or connection for a lot of different reasons. And then it starts to feed on itself. When you don't see that responsibility and connection, social media amplifies the dissent and the anger, and that generates clicks, and so it becomes more and more of that. I don't think that we get out of this simply by regulating our professions without regulating the megaphone that the algorithm uses in order to amplify both the conflict and the misinformation. If it was simply a flat platform where everybody had the same voice, that's a little bit different. But there is, in fact, an algorithm that promotes this component, which requires a different level of responsibility that we're currently seeing, and one that I would hope would be the next step in the evolution of what civic responsibility looks like.
Hi, thank you both so much. I'm Allison Mobley, a rising fourth-year medical student here. And at the beginning of the talk, you were talking about health equity and the focus of your career and caring for the vulnerable as like a core part of that. I'm wondering how you arrived at like that mantra or that like core principle and how that like informs your career choices and steps moving forward.
Yeah, I think coming up as a daughter of a poor immigrant family, you know, we got the government cheese. You know, I saw myself in that group. I was that group, and so you know, wanting to feel like I can give back by taking care of who I was. People who, a lot of times people don't want to take care of that group. You want to take care of the rich people who can, you know, do something for you in return, that there's so much, you know, maybe that you get back. So I'm just, you know, I've always wanted to either go back to my community of South Central Los Angeles or find similar communities in other states where I could serve that same community. So, you know, being, again, a daughter of immigrants, again, this is my reality. And so being able to give back to the communities or communities that look like the ones I came from has been so worthwhile and obviously so needed. If we really want to make a difference, you know what they say, a rising tide raises all boats, and so you really have to work to the lowest common denominator and make sure that we're working to get everybody up so that we can all progress as a society. I think you have a similar story, I know.
Mine is very much a justice orientation. I come from people who were brought here in chains and were held as property for generations and have always been struggling to make America what it claims to be. From people who have, you know, and at each point, we never thought it would be, right? Mm-hmm. There was generations where, you know, folks toiled and had their families separated, and then the Civil War happened, and then there were generations where folks were in Jim Crow and were unable to live under equal protection under the law and had extracted their resources and services. And when you grow up in a family of that nature, it is natural to want to work in a way that expresses a social justice agenda. And so working on the South Side and taking care of those who need the most help was a natural inclination for me. And so mine is not really a diversity or public health agenda. It's a social justice one, and one that is about reorganizing our society towards one that, that doesn't separate people from its resources, and in fact sees us all as similarly human.
Hi, my name is Michael. I'm a public policy student at the university, and this question's in a similar vein. As I'm thinking about my own career and how to make an impact within health policy, and thinking, okay, what area to go to and to make an impact. Can you talk a little bit about your career trajectories, both of you, and what led you from, to either stay in directly providing patient care or going to government, now coming back into providing more patient care or overseeing a health system, but what in that guides you and is drawing you back into those careers and keeping you there?
No, thanks for that question, and good luck to you. I definitely didn't have a map of, I want to do clinical medicine, and then I want to do it in jails, and then I want to go to state health department, and then there was no map like that. And so I think when you're presented with an opportunity, the question is this in line with my mission and vision? And so is it promoting health equity? Is it working with people who need it the most? And so all of the opportunities that I've had the answer to all of that has been yes. So I think once you determine what your guiding light, what your North Star is, then any opportunities that present themselves, you weigh it and say, is this getting me towards my North Star? And so they could be completely, it could be completely different than anything you could have mapped out, but someone who understands what drives you will see that the common theme is consistent with what they know to be your North Star. And that's how you can see how my different opportunities and my different experiences are actually all tied together.
I have the exact same story. There is absolutely, there was never a plan to do X, then Y, then Z. It was simply to express healthcare as an opportunity to understand the people that I care most about, to serve them, and to reshape a system that serves them better. And the decisions followed accordingly. I started out as an academic and then realized that it wasn't enough to know, you had to do. I moved into government and sort of larger organizations, hoping to reshape them towards more justice. And then I realized that institutions are loath to change. They have a culture that existed well before I got there. Oftentimes they began back when women couldn't be doctors and Black people couldn't get service, and they worked very hard to reproduce themselves in ways that keep a common culture, and so it makes it really hard. So now I'm thinking about, telling stories and building new things.
Hi, my name is Sophie. I'm a third year in the college, majoring in public policy. And as a public policy major, I'm always sort of looking for policy solutions. So I was wondering if you could speak to any policies on the state or federal level that you think would be beneficial or further health equity.
So I know, like at IDPH, what was my purview. We, under my tenure, instituted a health equity questionnaire, if you will. Anyone who's going to do business with IDPH, we had to see that your organization has actually worked with underserved people, are communicating to understand what actual needs are, that your plans to use our money have actually involved the people that you are trying to serve. How have you connected with people in these communities? And basically, like this health equity questionnaire is like 35% of the grant application. So if you have not shown that health equity has really been part of the program, that you are applying for money from us, you're not going to get that money. So you will go back to the table and try to be more thoughtful about how your program will help the people who need it most, and then you can come back and try to get some of this money. So I think those kinds of guardrails that help move people in the right direction is probably a good start, but there's obviously, so many, far-reaching things at the federal level that, people can think to do as well.
Yeah, I have very little to add except that it requires focus. This isn't something you can accidentally make better. We have a society that's been unjust since its beginning, and so unless we're actively working, it won't simply accidentally happen. There has to be intentionality and direction. So which is what you've done by baking it into those grants.
Hi, my name is Monica. I graduated from the Crown School last year. I'm a former educator turned organizer, and I had to take this opportunity to kind of ask this question because you talked about Medicaid. We have this really lofty goal of connecting all of our residents in our neighborhoods to insurance, right? And a lot of that push we're doing right now is through Medicaid. But I understand that tension between like the actual institute and Medicaid and connecting communities. So I think, and I'm just wondering, very briefly, I guess, what other options would you have for those that are struggling to have insurance, to have medical homes? Like, what other options other than just, I guess, Medicaid by itself? Because I know that puts the institutions on the financial buying, kind of like, how would we, or do you have any advice on how to go about that work, if that makes sense?
Yeah. I mean, I appreciate you just acknowledging that. I think inherent in what you're saying is that there's a two-tiered medical system. I mean, Medicare versus Medicaid, it sets up this top tier, lower tier of access to services. People struggle with Medicaid to find a specialist that will take them. And Medicare, it's like, come right in, So just that setup is anti-equity, right? It's completely anti-equity to have that be what people have. So what can you do while we're fixing that baseline problem? You have to promote things before people get to needing hospital care, right? We need a healthier base of people to start with. And again, that still comes into the social determinants because you obviously need to have resources to buy food. You have to have grocery stores that have fresh produce. You need to have safe spaces to play and work and sleep. You need to have enough education so that people understand how to keep themselves as healthy as possible. So keeping the populace healthy at baseline is a way to advance health even in the absence of equitable insurance for all people.
We've got two more questions.
Okay, my name is Jean Jenkins. I'm a member of the community. And, I was horrified a while back to discover the CDC is not allowed to look at gun violence as a public health thing. And then I got to thinking about that, and of course we had this judge recently saying you don't have to wear masks anymore because she has a weird definition of sanitation. And so I'm thinking, how much do both of you, how much have you had to fight against your own government to get to do things that need doing?
I mean, look, this is why we have a democracy, right? And so if we can breathe life into it in such a way that allows for the voices of the majority to fully be realized, then the judges and the CDC look like us, right? Whatever us means. And it requires that we are active and engaged and demand that, in fact, everybody can participate wherever we are and that those voices are heard. Now, we also have a government that was set up for minority rule from the beginning. I mean, women weren't voters. Black people were never a part of the Constitution. So it does demand that we make changes to these institutions. But when you do have a democratic voice, then you get the opportunity for these challenges to be solved. But these challenges kind of have to be looked at as multi-generational in nature. They don't happen quickly.
Hey, Mom.
My name is Adora, and I'm a first year at the college. And Dr. Fisher asked a great question about what you know now that you didn't know when you first started. So I just want to ask, how will you factor in what you've learned at your great 2.5 years at IDPH and your new role at Mount Sinai?
That's a hard one, girl. I think there were a lot of questions in there. Huge thing that I learned is you have to put your family first, even in the midst of all kinds of mayhem and, governor calling you at whatever time. You have to put your family first and make sure that you don't get caught up in all that's going on, no matter how intense or crazy the work is. I think in terms of, I hope to take that to Mount Sinai, to be able to strike balance even in the midst of intense challenges and probably incredible workloads. I think learning how important it is to have the right people around you, really building that strong team. We know how important that is, that we have to have people who are rowing in the same direction to really make some movement. So, and then also communication is everything. It's not enough just to speak. You have to make sure that what you thought you put out is what people received, and you have to tailor the message so that people can understand it. And sometimes that means finding different messengers to propagate that message.
So with that wonderful final question, I'd like to thank the Institute of Politics for having us in this lively conversation. The wonderful questions from the audience, thank you all for coming out and being masked and safe for one another and for us. And thank you, Dr. Ezike, for your leadership and grace. You made it look easy in one of the most difficult times that we've seen. Congratulations on your success, and we look forward to your next step.
Thank you so much. What a pleasure.